Welcome from our team. We are Fiona, Jecika, Chongshu, Jiayue and Samantha. Together we worked collaboratively to collect and combine our ideas for the following proposal and presentation. The National Safety and Quality Health Service standard we chose to focus on is Standard 6, Communicating for Safety. The intention of this standard is to ensure safe, purpose-driven, effective communication and documentation that is prompt to support the delivery of continuous, coordinated and safe care for patients. In particular, we are focusing on ISBA handover and how it was not correctly implemented in the scenario. Throughout the Learning from Error video, a major issue was the poor communication between doctor to doctor, doctor to nurse, or nurse to nurse. The multidisciplinary team did not hand over patient information and relevant instructions in a clear and concise manner. This breakdown of communication ultimately resulted in a fatal error. It is therefore crucial to use the national standard and ISBA to accurately communicate and document patient information to prevent medication errors. This will ensure accurate and timely documentation, whether it be verbal and visual communication of patient notes, patient identification, allergies, current health status, and reason for hospital admission, to ensure observations are communicated during handover and recognizing and responding to deterioration if the need occurs. Of patient's medication before administration, following the 8 routes of medication administration, ensure patient understanding and education about procedures being performed before, during, and after to obtain informed consent. Following up, should the need to escalate any unclear instructions, or should a colleague transfer duty of care to another staff member if they need to step out? Ultimately, improved communication and handover using ISBA will help decrease medication errors. Our aim is to improve in full the handover processes using ISBA between the members of the multidisciplinary health team to reduce handover-related medication errors reported in RiskMan by 80% within 2 months via the implementation of an electronic handover system. All health professionals involved with the patient need to be involved. These are the nurses, doctors, pharmacists, and other allied health professionals.
The National Safety and Quality Health Standards state that handover is the transfer of professional responsibility and accountability for some or all aspects of care for a patient or a group of patients to another person or professional group on a temporary or permanent basis. This is important because poor handover can lead to the ineffective care being implemented to the patient, which can result in disastrous outcomes. In the Learning for Error video, there was poor ISBA handover commenced between staff, which resulted in very few people knowing about who was administering the vincristine medication. There was very minimal handover between the multidisciplinary team, which resulted in a breakdown of communication. To address poor communication, Johnson, Jeffries, and Nicholas found that by implementing an electronic handover system, it improved verbal handover. This was done because it was found that communication breakdown between staff resulted in up to 70% of all sentinel events. The use of verbal handover mixed with aspects of electronic handover improved patient safety by reducing confusion and preventing gaps in patient knowledge for members of the multidisciplinary team. Our intervention is to implement a program in one Melbourne hospital where an electronic handover system is implemented. The electronic handover system will have the ISBA format template. ISBA is a structured approach to communication which includes identification, situation, background, assessment, and recommendation, which will provide a structured, systematic way of improving handover. By having the electronic handover system in the form of ISBA, it will provide a standardized approach to handover for the multidisciplinary team. The benefits of this system include legibility, ease of access, and monitoring throughout the shift and change of shift. The way we'll know that the program has been successful is the percentage of medication errors reported in RiskMan have been decreased.
Our intervention is to introduce an electronic handover system into selected wards in Melbourne Hospital, along with supporting strategies. Electronic handover system has been proved to be able to promote accurate recording of clinical information, reduces admissions in handover, and is easy to monitor staff compliance. An ISBA checklist will be embedded in the new system in order to improve the ISBA handover protocol among disciplinary teams. Additionally, education on how to use this system properly will be offered to the staff involved, and the participating wards will make policies to ensure the staff using the system during handover. Whether this intervention is an improvement remains a question, though the benefit of it has been discussed. To ascertain the effectiveness of this intervention, we will be organizing and testing it using PDSA cycle. In the plan stage, we need to find out the answers for the following questions. We are testing if the handover process between multidisciplinary team members will be improved by implementing an electronic handover system. with the expectation that the handover-related medication errors reported in riskman will be reduced by 80% within 2 months. This project will be starting on the 1st of May and lasting for 2 months. Patients and members of multidisciplinary team who take care of the patients, including doctors, nurses, pharmacists, and all other aligned healthcare professionals will be involved. We will conduct both quantitative and qualitative studies to collect data that can be used to determine whether this intervention works, including randomized block design and surveys. For randomized block design, we will randomly assign the interventions to participating wards and compare the number of handover-related medication errors reported in riskman between wards using electronic handover system and the control group. For the surveys, we will collect staff experience survey and patient satisfaction survey. If the number of handover-related medication errors reported in riskman in wards using electronic handover system is reduced compared to the control group, then we know the intervention is an improvement. Resources required include IT support, funding, educators, and policymakers. In the do stage, we carry out what's planted and observe from the process of implementation. In the study stage, we compare the observation with expectation and think about what we have learned from it in the act stage.
In this section, our goal is to measure and record the impact brought by the implements of the interventions. A randomized block design is applied for the experiment. We will block the clinical unit by the different requirements of medication administration. The number of blocks will be according to the actual situation of the hospital. In each block, we will choose 40% of this clinical unit as experiment samples. The samples will be equally and randomly assigned to each group. There are 3 experimental groups to testing the impact of electronic handover system and supporting interventions. And in each block, there is also 1 comparison group to determine the impact brought by the irrelevant variables that we cannot control. We will also apply a pre- and post design. We will collect the variable data before the implementations and set them as a comparison group. After the intervention implemented, we will follow up the experiment and collect the post-implemented data regularly for every 7 days. And then we will compare and analyze the data. Besides the incidence rate, we also want to check the safety of this experiment and see the other impact of interventions for future implements and future relative study. We will concretize the concept of impact into 2 more specific and measurable aspects that are listed below. Here's the experimental information for this study. We also want to determine the other impact of the interventions. These dependent variables listed in the right are all evidence-based that can be used in a study of handover interventions. Besides the incidence data collected from the risk-based report, we can also get data through questionnaires, interviews, and revisions of the documents. Here are the considerations of this study. We will use two-way ANOVA to determine significant difference among groups. In this case, ANOVA can also be used to determine the other impact of the interventions. And then we will use graph-finding procedure to do a post-hoc test. We will then indicate the data through suitable and relative statistic graphs. The result of this study may be biased because the samples are only from 1 hospital, and here are some suggestions for the future study.
Mohammed et al. 2016 noted a case in a Singaporean hospital. After a 6-month period, the use of the implemented electronic handovers decreased. They recognized that this was due to varying factors, such as a lack of efficiency in the program used and the deficiency of enforcement to use the electronic system. The researchers noted that the successful interventions to this was the use of reminders, such as posters and text messages sent to healthcare professionals every shift they were on call, as well as online education with a new protocol requiring junior doctors to watch the video and complete and pass an online quiz before going on call. Furthermore, Mohammed et al. 2016 also stated that enforcement from senior staff was commonly overlooked, but had a key impact on the success of electronic handovers. O'Hora et al. 2012 also noted that the use of a feedback system that is in turn used to improve the handover system resulted in more effective handovers. However, they also discovered that the implementation from feedback did not result in a gradual increase, but a sharp increase that only lasted a month each intervention created from feedback, but concluded this is likely being the result of constantly rotating staff. Using the finding of these articles, we should put in place implementations that include efficient and easy-to-use formatting for handover programs, automatic reminders sent to healthcare professionals each shift, education and training programs, at every turnover period with proof of understanding necessary before the healthcare professionals start working in the hospital, feedback collection and audits every few days after turnover periods, and support and encouragement for senior staffs to enforce the continued use of electronic handovers. If the trial is successful, it should subsequently be spread through Victorian hospitals. Morrow, Robert, Maben and Griffiths, 2012, acknowledged major concerns in spreading interventions, including ensuring staff had time to complete the training program and the evidence of impact. The way to improve impact has already been outlined, but all staff should be aware of this. Morrow and L. 2012 also noted other techniques to ensure widespread implementation, including regional support, central resourcing, stories of impact of change from other professionals in their field, encouragement and enforcement from an executive level, and accessibility to materials and support.
That's all for our group project. Thank you for watching.